An orientation of metabolic disorders, modern perspective. We have with us Dr. Pooja Gautam ma'am. She has done her MBBS and MD General Medicine from Lady Hardinge Medical College, and she's currently working as an assistant professor in the Department of Medicine at the same college. She has various publications at national and international journals, and she has a special interest in endocrinology. She has also attended various conferences at national and international level. Over to you, ma'am.
A very good afternoon to everyone. Thank you so much. I have got this privileged opportunity to discuss these metabolic disorders which are on a rise like anything. And India being the diabetic country, so it needs more emphasis on this metabolic disorders. So myself, Dr. Pooja Gautam, I'm Assistant Professor in Department of Medicine at Lady Hardinge Medical College, and we'll be discussing metabolic disorders, what is the modern perspective towards it, and Dr. Anupam Prakash sir is my moderator. He's the Director and Head of the Department at Department of Medicine, Lady Hardinge Medical College. So now what is metabolism? First of all, you should know what is metabolism. Metabolism is nothing but whenever the complex particles are being broken down to the simpler one to provide energy, that is metabolism. So now in that metabolism, we have enzymes, coenzymes, cofactors, which are responsible for this chemical reaction. In fact, hormones also do have a very important role in it. So whenever this chemical reaction is getting altered, it leads to metabolic disorders. Now, the metabolism can alter at the level of carbohydrate, at the level of fat, at the level of proteins, vitamins and minerals. So when cells are working so hard to fuel up your body, why don't we take an initiative to take care of ourselves? Because sedentary lifestyle, alcohol and all these factors, they contribute to formation of metabolic disorders. So if we talk about carbohydrate metabolism, diabetes mellitus, as we all know, is the most common metabolic disorder worldwide. And I believe every one of us or the relative might be suffering from diabetes. So one should be aware of all these metabolic disorders because we have certain inherited cause which we can't treat. But yes, the acquired metabolic disorders, which I'll be discussing further, we can control it via sedentary lifestyle, alcohol consumption, and all these factors are responsible for it. So before I discuss the metabolic disorders, just a quick review on how the medicine, the evolution of medicine from Ayurveda to allopathy happened. So as we all know, Ayurveda is the traditional foundation which dates back to 1500 before Christ era to 500 Christ era. And its main focus is on preventive and holistic care. So the balance of the three doshas, as we know, Vata, Pitta and Kapha, is the main emphasis in Ayurveda. But when we move further forward, the Greek medicine came into picture. So in that, basically Indian herbs and spices like the pepper and the spikenard, that was the spice which was used to treat issues like epilepsy in that time. They were being imported by Greeks and Romans. So the good thing was there was a lot of similarity between the Greek and the Indian medicine because both of them was based on Vata, Pitta and Kapha. Now when we move further, we came to Unani medicine. So it was influenced by the Greek humoral theory and also the Ayurvedic medicine. So there was a lot of transcription which was happening, translation which was happening between the Indian and the Indian Ayurvedic medicine and the Arabic medicine. Because this finally laid the foundation of experiment and pharmacology. So as one, just a point important to be noted, that the term diabetes also came before that. That was the 2nd century and the mellitus came around 17th century. So we do have a roots from Ayurveda. And then came the allopathy. As we all know, the term allopathy was coined by Samuel Hahnemann. And there were a lot of key developments happened in that era. I don't know if anyone is aware. Can anyone tell me who is there in the picture? Sorry, it's actually Edward Jenner. He was the person who made the vaccine for us. So yes, there were a lot of key developments which happened, like germ theory, which was postulated by Louis Pasteur, Robert Koch, and vaccination happened. And yes, anesthesia and antiseptics also came into picture in this era. And with that, we came with the British colonial era also came, where the Western medicine came into picture, and there was integration of both of them. See, the contrast is that Ayurveda mainly focuses on the holistic and the preventive approach, whereas allopathy mainly emphasizes on the clinical trials, pharmacology, and microbiology. And now is the era of modern medicine, which is evidence based, and we have specialization and advanced diagnostic methods in that. So, although allopathy did not directly evolve from Ayurveda, but yes, there are certain areas of influences like herbal medicines. Nowadays, also, our grandmothers, they might be using, cloves, cinnamon, turmeric, even now, also for the treatment of URIs. And along with that, we have surgical techniques. I don't know if you are aware of not. There is a procedure called neti, which was used to be done from the Ayurvedic set point of view, but nowadays it also being used for the treatment of sinusitis. Yes. So apart from that, both of them, whether it is allopathy or Ayurveda, both of them have the concepts like lifestyle, diet, and preventive, and both of them have a holistic health awareness approach. So yes, this is a shift from Ayurveda to allopathy, whether it is turmeric, which was initially used for, traditionally used for wound healing and for digestive health, is still now being used. Whether it is aspirin, which was initially used as an anti-inflammatory agent, still now being used for the cardiovascular diseases, or whether it is ginger, which still is being used. So, integration of both Ayurveda and modern medicine offers a complementary and a holistic approach. How? Because Ayurveda focuses on the preventive and the holistic thing, and allopathy focuses on diagnosing and treatment. Both of them contributing to physical, mental, and spiritual well being of the person. Same goes with personalized treatment. See, Ayurveda is more sort of a tailored approach. It looks behind what is the behavior of the person and what is the imbalance which is occurring in the person. But allopathy provides an evidence-based and it is a standardized treatment. Although both of them helps in reducing the side effects and improving the efficacy and healthcare of the patient. And yes, preventive healthcare point of view, if we say Ayurveda explains the daily routines, the seasonal regimens, and the immunity. And same goes with the modern medicine, but a different point. How? Via vaccination and screening. We have a national program for prevention of non-communicable diseases, which is happening at the national level. Then we have vaccination, universal immunization schedule is being there. So both of them together promote the comprehensive disease prevention. And yes, mental health, again, Ayurveda uses meditation, yoga, and breathing techniques to control anxiety and depression. Similarly, vis-a-vis goes with allopathy, which uses psychotherapy and medications. So ultimately, integration of both of them can have a balanced approach and can have improving the mental and physical health outcome of the person. But yes, when certain advantages come, there are certain disadvantages. Basically, Ayurveda lacks standardization and quality control. And plus, moreover, there are many drug interactions which can happen and can lead to toxicity among the individuals. But okay, fine, government is working on that also. So, let's come on to the metabolic disorders now. First of all is the diabetes mellitus. So there is an abnormal carbohydrate metabolism. Along with it, there is an insulin deficiency or there is insulin resistance. So if we go by the figures, this was the data. India is the second diabetic country in the world, mounting to almost 89.8 million individuals suffering from diabetes. So we have this criteria which is postulated by American Diabetes Association, wherein the A1C level more than equal to 6.5% or fasting level more than equal to 126 milligram per deciliter or a 2 hour per annum blood sugars are more than equal to 140 milligram per deciliter, or if the patient is landing up in hyperglycemic crisis with a random blood sugar of more than equal to 200 milligram per deciliter. So yes, we do have a screening program via national program for prevention and of non-communicable disease, wherein the screening is to be started at the age of 30 years of age. So that was the one metabolic disorder. Now, when we come to another one, dyslipidemia is again a very common problem in Indian context. Why? Because it was being seen that we as Indians, we have a more atherogenic potential, and we are bound to develop an atherosclerotic cardiovascular disease a decade earlier than the Western population. Why? It's just because of a lifestyle that's coming into picture. Nowadays children are glued to screens. Sit food, have food, and they are just glued to whether it's technology or whatever you can say. So that is hampering, and we are seeing many deaths which are occurring in young just due to the cardiovascular disease. So it's very important, one should be aware of it. And definitely our epidemiology differs as compared to the Western countries, and that's why when we treat it, our targets are more stringent as compared to the Western population. So first of all, whenever a patient comes, we should do risk stratification for it. These are the risk factors. We have major risk factors, we have risk modifiers, and then we have high risk factors. So once you calculate the risk, we do the stratification, whether the patient is having a low risk, a moderate risk, high risk, a very high risk, and extreme risk. One should be vigilant that once the patient become a diabetes, whether he has an end organ damage or not, the patient fits in very high risk. So we need to start up with a moderate or high intensity statin in those patients. So now once you stratified it, you should know who to treat. So basically, who are low risk individuals and moderate risk individuals, we initially go with lifestyle modification, and if that is not able to control it, we go with drugs in the form of statins, pharmacotherapy, single or double therapy can be used. And in case if the patient is having a high risk, from high risk to very high risk, again the treatment remains the same. We need to start off with the statin therapy and individualize accordingly. Now, once you treat it, one should know what is the target. As I was discussing, we have more stringent control because the LDL, which is the most atherogenic in our body, our target is to keep it to less than 70, and in very high risk, it is less than 50. So yes, more, very, very stringent control is required as we have a high atherogenic potential as compared to the Western countries. Now, let's come on to another metabolic disorder, gout. So, if we talk about global burden, 55.8 million individuals are suffering from it, and we have a modifiable and non-modifiable. See, non-modifiable, we can't change it because with age it increases, it's more common in men, we have certain genetic transporters which can hamper the uric acid metabolism. But yes, we can pay attention to some modifiable risk factors like obesity, hypertension, hyperlipidemia, diabetes mellitus, and in that diet plays a very important role. In fact, whenever a patient of gout comes to the OPD, we advise them what all not to take, because these things like the foods which are rich in purines like red meat or alcohol, they all increase the purine concentration in the body, ultimately increasing the uric acid itself. And some drugs like diuretics can also lead to apparent hyperuricemia, and if the patient is already having diabetes, hypertension, that itself places them at a high risk of developing gout. So now once we have found out if the patient is suffering from gout, how to treat it, whom to treat it basically. So patient can come in acute flare up where the patient can have pain at the most common joint is metatarsophalangeal joint. Patient can come with pain and swelling. At that time we advise them steroids, analgesics and colchicine accordingly. But for the patients who require a long term urate lowering therapy are the one who have 2 gout flares per year, or who have deposition of monosodium urate crystals in the joints or in the skin. In the skin, most commonly it's around the pinna, and if there is any radiological evidence of joint damage. But in case if the patient has only one flare in a year, then in that case, if that patient is having a chronic kidney disease, any urolithiasis, or has a urate concentration of more than 9 milligram per deciliter or higher, in that case also we should start urate lowering therapy. Now, yes, the second comes the hypertension. After the diabetes, hypertension. The global burden amounts to 1.8 billion individuals. India has a prevalence of 43%, so very high. And that's why we have these American Heart Association guidelines, and also guidelines from American Cardiology of College of Cardiology, wherein distinction is made on the basis of BP, whether it's normal, elevated, type stage 1 or stage 2 hypertension. There are 2 more emergencies, hypertensive urgency and emergency. That's a different thing. That's hypertensive crisis basically. So once you have hypertension, you have diagnosed it, you should know whom to treat it. See, it can be done at the secondary level prevention. Okay? In that, if the patient is having any cardiovascular risk factor with a systolic blood pressure of more than equal to 130 and diastolic more than equal to 90, we start antihypertensive medicine. For primary prevention, if an adult is having a risk factor of more than 10% with a systolic of more than equal to 130 or more than or diastolic more than equal to 90 millimeters of mercury, in that case we need to start treatment. But in case if the patient is having a risk factor of less than 10%, however, the systolic blood pressure is more than 140 or the diastolic is more than 90. In that case, for primary prevention also, we need to start medication. And apart from that, any patient who is having diabetes with chronic kidney disease or any patient who is having age more than 65 years and above, and we have these readings, so we use for therapeutic management of hypertension. The next comes the thyroid disease. Again, very common in the OPD. Hypothyroid, and amongst the thyroid disorders, hypothyroid is more common as compared to hyperthyroid, and in that case, subclinical hypothyroidism amounts to 4 to 10% of the cases. So we should know what is subclinical hypothyroidism. Basically, patient is not having any complaints, but the patient have a biochemical evidence of thyroid dysfunction in the form of TSH, which is altered, although FT3 and FT4 are normal. So TSH is in the range of 4 to 10. So that is the case where we label the patient as subclinical hypothyroidism. So in that case, if the patient is pregnant, infertile, antibody positive, if patient is having any cardiovascular disease, or if the patient is having any symptoms, we need to treat the patient of subclinical hypothyroidism. Same goes with subclinical. If the patient is not having any symptoms, but the TSH is less than 0.1 with normal FT3, FT4, or if the TSH is more than 0.1 and the patient is having any evidence of symptomatic heart disease, we start the treatment. So in the last, I would just like to say that all allopathy did not directly evolve from Ayurveda, but Ayurveda helps in knowledge enhancement, inspiration, and it helps to shape modern medicine in areas like surgery and anesthesia and preventive care. Thank you so much.
So, but when the patient comes to you or us, either way, so it is not always easy because patient does not want to go to multiple doctors. As patients ourselves, we also do not want to go to multiple doctors. And to provide treatment encompassing, as Dr. Pooja said, holistic view or what is holistic medicine, it is not always easy. So, what is your opinion? What is your expectation? What do you want to know from us, or any clarifications we will be glad to offer? Anyone? So, what information you want from us, we will be offering. Don't worry. Apart from the slides, also. So, all these things, we already, the guidelines are mentioned, the references are also mentioned in the SDG, the standard treatment guidelines, the protocols. We have a fair set when actually to refer a patient, and the guidelines for screening are also quite clear. So now what will be required is probably that we will need to stick to these SDGs, because once they are floated, so we will need to ensure that we stick to them, because it encompasses a whole lot of things: screening, evaluation for risk factors, when to refer, and as Dr. Pooja also said, the ASCVD calculator, the atherosclerotic cardiovascular disease risk calculator. So we have risk calculators. So everything is objective and the information is too much. It is not easy to assimilate, because we also at times, there are newer risk indicators, risk calculators which keep coming. Even if there are no newer risk calculators, there are calculators which keep getting updated. So you have, and there we also have, and the problem is that most of these risk calculators are West based. The simple ASCVD scoring or the risk calculator that Dr. Pooja addressed to is also West based. And as Dr. Pooja said, we have the onset of metabolic disorders a decade or two earlier, 10 to 15 years earlier. Now these diseases occur later in life, especially with longevity of life and better medical care in the West, they occur later. So as with this calculator, the ASCVD calculator, it does not include people who are less than 40 years old. because it starts with 40 plus, because that is the age classical for them. They cannot have a calculator based upon less than 40-year-old, because that disease does not occur. Hypertension, diabetes usually does not occur in a younger age group in the Western population. So they do not have the epidemiological data. General population data is missing there. Their trials do not have that data, so robust data that they can have it for less than 40-year-old. So we cannot calculate. But that data needs to be generated here now, because otherwise we cannot project the calculator that you can never calculate if your patient is less than 40-year-old. And our patients, you all will agree, they are less than 40-year-old. Diabetes, hypertension, dyslipidemia. So all these things are occurring in lesser population. And at times, these are the gaps when you treat or we treat. These are the gaps. Despite presence of risk calculators, at times we do not have for our targeted age. In fact, that is most if you want to calculate 10-year risk, it is more important for a younger person as compared to an older person, relatively older person. But that is the gap that we have: technology gap, data gap, research gap, evidence gap. That is there. So we all will need to generate evidence, and we need to publish that evidence. Otherwise, we will still lag behind. That is just a point that I wanted to make. Anybody else wants to contribute? Otherwise, you can have an early tea. Yes, please.
The thing which you told is not true as far as my when I'm coming from Pondicherry.
Hmm.
So there actually the patients go to allopathy and they come to us. So we don't have any issues with that.
No, that is not an issue with here also. But the problem is that when the side effects occur, then who takes the responsibility? Because there is a fair degree of, even with single pathy also, you can have side effects. Everything can have side effects. So when the patient is taking double or two pathies treatment, so at times when the side effects occur, who takes the responsibility?
Here actually it is, we are also maintaining it the record of the patient. Because since allopathy has got a better record maintaining than we Ayush people have got. They have got all this Aadhaar based things also right now. So with that, I think later on it will come. ABA is coming down. So after that, what we see is not side effects, actually side benefits, because we are able to control the diabetes a lot, getting a lot of diabetic patients out of it, especially long-term administration of statins is actually doing a lot of harm, and that we are actually cutting it down. And we found it very good. The
so
patients are
that
improving a lot.
evidence will need be required.
Yeah,
that is
that's
very
what.
important.
And we are not able to document it. That is the only problem where we are slowly talking with our administration.
Either side of any pathy, we are all human beings.
Yeah, because actually
So we are not actually in the habit of maintaining those records. Even we are also very poor at maintaining records. So it is not because of the any pathy. We are all human beings, whether we are inside of Ayush or in modern medicine. So documentation we all will need to imbibe. It is important for all of us to have proper documentation, because then only we can actually allude that this side effect is because of this. Otherwise, in the medical legal aspects, it becomes very problematic. Who owns up the responsibility? It is not about that we are not owning up the responsibility. So because we are all in a setup, if we are documenting, then it is genuine. Otherwise, it is hard to the patient. So ultimately, we are all working for the benefit or welfare of the patient. So if any harm occurs to the patient, irrespective of the pathy, it is loss to humankind. That is the only thing.
सर एक जनरल क्वेश्चन पूछना चाहूँगा, जैसे दोनों पैथियाँ जरूरी होती हैं, अभी मैम ने बताया था जब हाई रिस्क में पेशेंट आ जाता है तो एलोपैथी भी देते हैं उसको, हम आयुर्वेद भी चलाते हैं, तो दोनों में इंटरेक्शन ना हो, कितना गैप होना चाहिए आयुर्वेद की और एलोपैथ दवाई में? एक जनरल क्वेश्चन सर, पेशेंट पूछता है।
ये कहीं तो हमारी स्टडीज में लिखा नहीं हुआ है कितना गैप होना चाहिए, लेकिन जो we are taught in pharmacology, as you all will agree, that 5 half-lives of the drug. So the problem is, जैसे ट्विन पैथी अगर ले रहा है आदमी, डुअल पैथी ले रहा है, तो अब दोनों डॉक्टरों को साथ में मिल करके देखना पड़ेगा. Now the problem is, if there is an emergency, then the patient goes to modern medicine, and there we lack the other pathies. So we are not able to treat those patients according to the emergency medicine. People are not able to treat those patients according to what has been given and what is the duration or 5 half-lives. So that is what I am saying, that has to be now available, because now we have all distinct pharmacopoeias, and those pharmacopoeias actually, whatever is given has to be actually aware to everybody. So that is why I would thank the organizers to having this session, because unless until there is an interaction and there is ignorance is removed and awareness exists, this kind of interaction is very important. So we will need to know the 5 half-lives. Or please be seated.
One question I would like to ask. Thing is, in modern medicine, the cholesterol concept, whatever it is there are several modern researchers who have written articles and on the cholesterol, stating that it is not that much harmful.
It is not that much
Not that much harmful. Even taking the cholesterol itself could be the anti-hyperlipidemic drugs. That could be harmful.
That is what he is also saying.
Yeah, because there are certain articles where it is mentioned that it can cause diabetes, it can cause
Yes.
myopathy,
Agreed.
and even it can also delay the remyelination process, so which is involved. And also there is no direct evidence that the lipid profile, high lipid profile is of dyslipidemia is going to really harm the patients. And because we have seen several patients with dyslipidemia more than 30 years staying normal without much problem, but is it not unwise for patients to really put them on hyperlipidemic drugs for so long, which may cause really harm to them?
See, I totally agree with you. I totally agree with his viewpoint also. But the problem is that those who prescribe or advocate statins, they have robust evidence to support. We do not have evidence to support. So if we have an evidence that yes, those who have lived in India for more than 80 years, they have attained 80 years, 90 years, and we know that if we draft how much has been their lipid profile, and they have not taken any anti-hyperlipidemic drugs, but where is that evidence? So see, today everybody, see, if you go to the court will say bring evidence. Kanun andha hota hai. So court is blind, justice is blind. So what you show, that will be seen.
So in this regard, we would like to suggest to the Ministry of Ayush also here and
Nobody
collaboration
is,
with
madam is there.
modern science.
So nobody is there, don't suggest.
That you can discuss during the concluding
Just
session.
one point, because in Ayurveda we use a lot of key medicines. We keep on giving, and for months together we give, and still we doesn't see any harm happening to the patient.
Sir, we will need to document it.
Yeah, exactly. That's the reason what I feel is that it's such a podium. I want.
I totally agree. So this is the message for each one of us, including us, that we need to document everything.
Because we keep on treating the patients with key medicine.
So the core is that build up evidence. Build up evidence, whatever you do, even if you treat 10 patients, 20 patients, 50 patients, build up evidence.
There are evidences published by the modern researchers themselves on the concept of cholesterol.
So then the next step is highlight them.
There are several papers are available, sir, in the Google. We can see them that the modern researchers they
So
themselves say
just
that-
like modern medicine people are doing meta-analysis and systematic reviews, now you also do and highlight it.
it started. Hopefully,
That is what I am saying. So these are steps where we will be able to take our traditional medicine much higher.
Yes.
There are
So-
the researches who are already published.
Yeah,
There are many researches over the period.
That is what I am saying. Bring them to visibility.
Modern people have to see that their researches.
See, it is no use showing to modern people. See, then you will never be able to do it.
Are published.
Even if I see it, I cannot practice your path.
No, I am not talking about practice. I am
So
talking about.
then it is no use showing it to me, na?
Yeah, you are not.
It is no use showing to me because I cannot practice it. Even if I am convinced, I will not be able to advocate it. So you have to use your own channels, publish and project. Then only you will benefit.
IA is publishing. Every institutions we are working on. National Institute of Ayurveda is there. IA is there. These people are even some must have.
So that is good. Good. Wonderful then.
Yeah, another thing is actually hypertension. Because any initial hypertension, they just simply write without the standard thing of checking the BP 3 times a day, at least in 3 positions. So that is not followed most of the places, and you are able to just by mild massage of the neck itself, we are able to relieve many of the cut off all the hypertension.
So that is what Dr. Pooja said. Prevention and holistic approach is more important.
Spondylitis itself is leading to hypertension.
So we are not denying the importance of your
Here we need to work together.
but the thing is we have to work together.
Yeah, exactly. This is what
We
I
have to work together, that's it.
That is what we would be able to have.
Thank you so much, ma'am.